Hello and welcome to today's webinar, Strengthening Support for Family Caregivers, Lessons from States. Made possible with support from the John A. Hartford Foundation, the Milbank Memorial Fund, the May and Stanley Smith Charitable Trust, and the Gordon and Betty Moore Foundation. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Courtney Roman, Senior Program Officer at the Center for Healthcare Strategies.
Thank you so much, Travis. Welcome to everyone. We're so delighted you all are joining us for today's webinar. I'm Courtney Roman, I'm Senior Program Officer at the Center for Healthcare Strategies, and together with my team here at CHCS since May of 2018, we have led a learning collaborative of 6 states focused on improving family caregiving policies and programs in their states and communities. In our time together today, you are going to hear from speakers in 3 of those states, Virginia, Idaho, and Iowa. Each will highlight a key element of their work that led to foundational change in family caregiving policies and programs. And then we'll wrap up with ample time for Q&A. Next slide, please. Great. So now I'd love to introduce our speakers for today. First, we're going to hear from Jason Rachel, the Director of the Division of Integrated Care at the Virginia Department of Medical Assistance Services. You may know them as DMAS. Next, we'll hear from Judy Taylor, the Administrator at the Idaho Commission on Aging. And Judy will be joined by her colleague, Sarah Taves, the Director for the Study of Aging at Boise State University. And finally, we will hear from Julie Burgenson, the Family Caregiving and Support Services Manager at the Iowa Department on Aging. So huge thanks to all of our speakers for taking the time to be with us today. Next slide, please. So for those who may not be as familiar with this initiative and our participating states' work, I wanted to provide a brief overview. The goal of this initiative, helping states support families caring for an aging America, was to support our 6 participating states, Alabama, Idaho, Iowa, New Hampshire, South Carolina, and Virginia, in shaping, redesigning, and improving family caregiving policies and programs through a learning collaborative. The project kicked off in May 2018, and it officially ended on September 30th. 4 funders supported the first phase of this project: the John A. Hartford Foundation, the Milbank Memorial Fund, the May and Stanley Smith Charitable Trust, and the Gordon and Betty Moore Foundation. And a sincere thanks to all of them for their very generous support and guidance over the course of this project. So over the last 2 years, the 6 states participated in a learning collaborative, and that means that we fostered an environment where they could talk to, share with, and really learn from each other. And we found this aspect to be the part of the project that states appreciated most, just being part of a community where they could connect with each other. We then provided a model of technical assistance where states worked with us closely and frequently as we supported them in their work, and we offered strategic guidance, gathered resources, and developed tools to respond to needs. In light of the current environment, I would be remiss without acknowledging the pandemic and what our project states faced when COVID-19 swept the nation in the spring. Our project states were all profoundly affected since the populations that they work with family caregivers, Medicaid, Medicare beneficiaries, et cetera, were the ones often most at risk of contracting the virus. And in the months that followed, they all had to pivot priorities, re-strategize, kind of take an all hands on deck approach to navigating the unprecedented situation in their communities. And states are facing entirely new terrain while trying to develop safe and creative ways to support family caregivers and vulnerable individuals amid increased safety precautions, service disruptions, and a sudden loss of formal paid caregivers. This is not easy by any stretch, and our team at CHCS has been really fortunate to see our project states take on these challenges and demonstrate how committed they are to this population. So of course, there's more work to do, maybe now even more than ever. So as I mentioned, the first phase of this work ended as of yesterday, and we are delighted to be receiving support from the John A. Hartford Foundation to continue on with the second phase. So phase 2 kicks off officially this month, and we will be recruiting states to participate. If you'd like to learn more about phase 2, please feel free to contact me or any member of our team. And I know that my contact information is going to be placed in the chat during the presentation, so you have that there. Next slide, please. So on Tuesday of this week, CHCS released an issue brief on this project where we highlighted the work of all 6 participating states. And in that brief, we discussed a set of key elements that were needed in order to make foundational program changes to support family caregivers. And each of our speakers will describe how their work aligned with one of the key elements. The first element is to prioritize cross-sector engagement. One of the hallmark features of this project is that each state established a cross-sector team that came together to complete the work. This meant that state teams were working with agencies and organizations that they didn't normally have the opportunity to partner with, including departments on aging, area agencies on aging, Medicaid, Health and Human Services, and also organizations in the private sector, so such as state chapters of AARP, the Alzheimer's Association, and universities. Working in cross-sector teams really helped to break down silos, and states reported being able to do more together than apart. The second element is to collaborate on shared goals. So related to the cross-sector element, once state teams came together, the strategy that provided the most momentum was identifying shared goals that the team could really get behind. With so much work to be done, it's easy to get distracted by competing priorities, but if the team can maintain their specific shared goals, it really leads to less duplication and more creative and collaborative approaches. And finally, the third element is to establish robust data collection and exchange. So data collection was such an important issue for all of our project states, both building an infrastructure and collecting meaningful data. States often felt that supporting family caregivers started with data collection, really. You have to know who the family caregivers are before you can design programs to best help them. So therefore, collecting data really strengthens the state's understanding of family caregivers and their value. And additionally, having meaningful data that can be shared with other agencies, organizations, and stakeholders is really critical too for advancing the work. So without further delay, I'm going to turn things over to our speakers, and we will be starting with Jason Rachel from Virginia. So Jason, over to you.
Great. Can you hear me, Courtney?
We can.
All right, great. Thank you, Courtney, and hello, everyone, and thank you for the opportunity to speak with you today regarding Virginia's work in the area of supporting family caregivers and what we were able to accomplish through working closely with CHCS. And allow me just for a moment to say thank you, a sincere thank you to CHCS for making this opportunity possible. We gained so much from it, and we're so delighted by the momentum that it's created that we can continue this work going forward. Next slide, please. So first, a little bit about us. As Courtney noted, my name is Jason Rachel. I'm the Division Director for Integrated Care. And that program oversees our Managed Long-Term Services and Supports Program, fondly known as Commonwealth Coordinated Plus, or CCC Plus, and is an integrated delivery system comprised supporting the medical, pharmacy, behavioral health, and long-term service and supports for approximately 260,000 vulnerable Virginians. And this is administered through 6 health plans. And the unique aspect of our program, or certainly until CCC Plus came along, it just didn't exist for the Virginia Medicaid population, is an assigned care coordinator for each of the 260,000 members. And we saw this opportunity between the care coordinator and the member to be able to identify and engage with family caregivers. And so we were really excited by the opportunity to participate with this project, and I look forward again to sharing you some of the accomplishments and lessons learned in just a few minutes we have today together. But that said, we wanted it to be more than just the 260,000 members that we served through the MLTSS program. And quite frankly, we wanted it to serve beyond the 1.8 million Virginia Medicaid recipients that we currently serve. So we wanted to partner with our Department of Aging and Rehabilitative Services, or DARS, or our State Unit on Aging. Next slide, please. Because we knew the importance that the partnership, the core team partnership would really help us expand our reach. And as Courtney noted very correctly, we can do more together. And so we knew by partnering with DARS, we would be able to reach more people, reach more family caregivers. Yes, there are quite a large number within the Medicaid population, but through the multiple programs, the many programs that DARS offers, we knew we could expand that reach. Some of those programs include respite care, legal assistance, the public guardianship program, the long-term care ombudsman program. All of those programs offered by DARS, there are associated family caregivers, and by again coming together, we could do more. We wanted to do that. We knew we had to start the partnership at the core team. And so very quickly, just wanted to acknowledge all the great work of my DMAS colleagues, Sandra Brown, Katie Hill, and Tammy Whitlock, our Chief Deputy for Complex Care, and then of course our partners at DARS, and specifically Linda. What a great partnership we were able to forge through this program, and again we look forward to working together going forward. Now, the overall project goal for this project we had was to develop tools to engage and support family caregivers to strengthen home and community-based living, right? Because that's where it's at, community-based living. And we all know that if you support the family caregiver, you better support the member that you're serving. And that's what it's all about, right? I mean, that's what we're trying to do here. And so again, and knowing that we were able to come together and kind of expand our reach, we were just very excited by that opportunity. Now, the first thing we wanted to do, next slide please, was to create a multi-stakeholder work group consisting of, again, our 2 state agencies, our 6 health plans, and those community organizations. Again, Courtney noted earlier, and just how important they are in kind of bringing together the various groups and efforts, quite frankly, efforts in supporting caregivers and bringing them all together, like AARP, the Alzheimer's Association, and many others, just in Virginia alone. And we were able to come together, and I was amazed, quite frankly, I was amazed by how much was being done by program specific or entity specific around supporting family caregivers. And I was also surprised by I wasn't aware of it, and our teams weren't aware of it. That wow, I didn't know the AARP was doing that. I didn't know some of our own health plans were doing things to support family caregivers that we weren't fully aware of. And so it was the stakeholder work group, the multi-stakeholder work group, really was able to bring to the surface all of these great pockets. Let me get my hands in the frame. Great pockets of programs to support family caregivers. And by convening the multi-stakeholder work group, and we were able to create natural linkages, and it was amazing. It was really amazing to say, oh, hey, we can work together here, and I can take this resource that you already have and apply it to the population that I'm serving, and vice versa. And you know what? It doesn't even cost anything. It was just a matter of time and bringing the right people around the table. And I'll say this, as a longtime state employee, as a longtime someone in the healthcare delivery system, you know, we rely on work groups, right? We rely on coming together to bring, to do more with less, right? That's just the name of the game. But you know what happens, and because you've been there, you've been around that table, there's always a few that disagree, a few naysayers. Well, let me tell you, and I don't make a lot of guarantees, but I'll guarantee this. You bring people around the table to talk about family caregiving, and you're going to get instant buy-in. It was beautiful. You get instant buy-in because everyone can relate to family caregiving. So for the states out there that are looking to do more, for the community organizations that want to do more, get around the table and just start talking, because you'll be amazed at, again, that instant buy-in and the collaboration that you can create and with relative ease. It was just really fun. It was very motivating and exciting to see, by bringing people around the table and talking about it, and hey, what are you doing? What am I doing? My population that I serve would benefit from this. And so again, just tremendous amount of gains from these multi-stakeholder work group that we created. Next slide, please. So some of those gains, and I'll just go over quickly with you, is the partnership with Virginia Navigators. So jot this down real quick, virginianavigator.org. Now, yes, it's Virginia specific, but you might find that you have something similar in your state, or you might find, hey, this is something we want to do in our state or in our area. virginianavigator.org, is a statewide nonprofit online directory and guide of information and services, and has 26,000 local resources listed. And we created a very strong partnership through our collaborative work group, and did a promotion, an email campaign to both our members and the caregivers, as well as our care coordinators through our training with them. So an excellent partnership that we will continue. Also, we did DMAS joined the Virginia Caregiver Coalition. This is a group of individuals who got together who want to promote and strengthen family caregiving. Hey, this is right. We weren't part of it. Now we are. Right. Great. Really great. And then a caregiver survey. We were through CCC Plus, we have an evaluation to members that we serve. But we said, hey, you know what? Let's have an insert that that provides an opportunity to hear directly from the family caregiver. Now, unfortunately, next slide, please. Unfortunately, the timing didn't quite work out, and I'm sorry to report that we don't have the results to share today. We administered it in the middle summer, and then we've kind of gotten those results in, but they haven't had a chance to be analyzed yet. But that will be the first thing that we do when we reconvene this work group and our work group here in Virginia around supporting family caregivers. And we're going to let the survey and the voices of the caregivers that responded drive us to what we do next. And so we're real excited by that opportunity to hear directly from caregivers, right? You know, yes, you can build it, and Field of Dreams, they'll come, right? That's true sometimes. But you know, what's also great is if you can ask them what they need, and then either identify or create that need or that program to help to fill that gap. And so we're very excited about that caregiver survey. And as I noted earlier, the momentum that the project created and the momentum we were able to achieve through convening the work group and developing these strong collaboration and partnerships will really will be the energy that moves this program along, again, even beyond this project. So again, very excited to see where this takes us, this results takes us next. So in my closing minutes, last slide, I just want to go for a few of the lessons learned. as I noted, you may be pleasantly surprised about how many program-specific resources are out there for family caregivers, and that by convening a work group, you might be able to just create very natural linkages between groups served and resources available. Again, we found a tremendous partner in our health plans, our 6 NCOs, in that not only did they buy into how much you can get out of supporting family caregivers and how much it can do to improve the overall care delivery system, but it was, but they would be a great vehicle in supporting and kind of making known the resources, and a great vehicle to identify family caregivers and assess what their need is, and then direct them to a resource that would fill that need. So again, great partners within our health plans. And then lastly, pleasantly surprised again, there was a lot that we were already doing on both the DARS side and the DMAS side, in the programs that we administer, that we could take that existing work and then just add in a kind of a slant to family caregiving. So, it's as simple as, right, most programs have some type of assessment, right? So it's as simple as this: just turn to the family caregiver, right? It was like, hey, of course, why not? Let's just turn to the family. Hey, how are you doing, right? We know that the needs of the family caregiver go up and down, and sometimes things are fine and sometimes they're not. And wow, and you just, engage with the family caregiver and kind of have them in the forefront, at least as part of the assessment, then you can identify, address the need, and really help support. So I'll pause. I know I'll stop there. My time is up. Thank you all very much. It was a pleasure to speak with you today, and I understand that we'll do the Q&A at the end. So at this point, I'll turn it back over to Courtney. Thank you all.
Thank you, Jason. Such exciting work. Thanks for sharing all of that with us. So now I'm going to turn things over to our friends in Idaho, and we'll start with Judy and Sarah. So you all can take it away.
Sarah, do you want to bring up our first slide? There it is. Good morning, everyone from Idaho. I'm Judy Taylor. I'm a nurse by profession, but for the last 3 years, I was appointed by the governor to lead our state unit on aging, the Idaho Commission on Aging. We're thrilled to be with you here this morning. I'm going to start by setting the stage about Idaho culturally. Idaho has a very low population density. We're underserved in all healthcare professions. The majority of our primary care is delivered by advanced practice nurses, and we have 27 critical access hospitals across the state which serve as many Idahoans' main access into healthcare. Idaho government is expected to be transparent, efficient, most of all non-intrusive into the average citizen's life. Governmental resources are viewed as the resource of last resort. Because of that, Idaho has a very long-standing culture of collegial cooperation, both within government and between government and the private sector, the business sector, the not-for-profit sector. It is expected that state agencies cooperate with all those stakeholders and that they produce results for the citizens. There is really no ability to hide in Idaho because of our low population density. Within Idaho, you are very quickly known by your reputation and by the outcomes you produce. So with that little cultural reset, I would like to turn the presentation over to Dr. Sarah Taves, who's going to talk to you about our project, and then I'll rejoin you at the end and talk about our lessons learned. So Sarah, why don't you take it away?
So good morning. Thank you, Judy, for setting that tone, and a shout out to Jason's presentation. I think we're going to see some very common themes about the opportunities to collaborate, particularly around this relatively invisible population of family caregivers. And again, a shout out to the Center for Healthcare Strategies as well. Courtney and her team have just been incredible in helping us move a project forward. So at the outset, the initial vision for the Idaho Center for Healthcare Strategies project was to establish a public-private partnership to enhance caregiver support's access to information and services. From the perspective of our team in Idaho, which was comprised of individuals from the Idaho Commission on Aging, the Area Agency on Aging, the Division of Medicaid, a representative from the legislature, and members of the Idaho Caregiver Alliance and staff with the Center for Study of Aging at Boise State, the public-private partnership element of the project was key. We felt it was key to stakeholder engagement and project sustainability in a state where resources for social services are difficult to secure. This public-private partnership also capitalized on existing relationships enjoyed by members of the Idaho Center for Healthcare Strategies team. So our initial vision, crafted almost 2 years ago, was to partner with the Idaho Division of Medicaid, the insurance providers offering the managed care plans to individuals enrolled in a new dual eligible program in Idaho, and the Idaho Commission on Aging and area agencies on aging to enhance caregiver supports and access to information and services. Well, this is not where we landed. Rather, we worked with the Idaho Division of Medicaid to identify shared goals and launch a telephonic caregiver support program in one region of the state. This partnership was sealed not with a handshake, but with a safe and socially distanced virtual elbow bump in June of this year. So recognizing that COVID-19 definitely changed some of our plans and trajectories, but partly in light of the fact that we had visioned a telephonic intervention at the outset, we've been able to move forward and make progress. So just to touch on some of the key elements of, I think, the foundational success of our project and the work that we've accomplished so far, it's really around this notion of having a statewide network of trusted partners. And in Idaho, and in the world of family caregivers, this has really been established through the Idaho Caregiver Alliance. The Alliance has been in place for approximately 8 years, and we work to engage community members, agencies, and policymakers. And as Jason mentioned, this power and energy of bringing entities together to talk about family caregivers has been incredibly informative and enlightening. We have learned the language of behavioral health through this initiative. We have learned the language of the Idaho Parents Unlimited. It has expanded, I think, all of our horizons in thinking about our common kind of foundational resource that we all depend on in the family caregiver as we move our work forward. The Alliance is supported through funding from the Administration on Community Living, through their Lifespan Respite Initiative, and it is co-facilitated by the Idaho Commission on Aging and the Center for Study of Aging at Boise State University. The vision of the Alliance is to serve as the voice, convener, and catalyst for support of unpaid family caregivers across the lifespan in Idaho. Accomplishments of the ICA include a statewide assessment of caregiver needs and respite services, implementation of an evidence-driven action plan, sponsorship of an annual caregiver conference, regular presentations to members of the legislature, and a pilot caregiver integration project conducted in partnership with a local public health district and primary care providers. These laser-focused caregiver support ventures and other initiatives have established name recognition and credibility for the Alliance. And as noted by Judy, it is difficult to hide in Idaho. You are known by your reputation. and the outcomes you produce. So using ICA as the vehicle and the expertise of members of the Center for Healthcare Strategies team, we were able to bring the right people to the table for an open exchange of ideas and discussion of shared goals. We realized that making a pitch to the Idaho Division of Medicaid for caregiver supports would not be easy, due primarily to the organizational structure of agencies in Idaho. Aging-related services and much of the existing caregiver support programming is under the purview of the Idaho Commission on Aging, which, as Judy mentioned, is a standalone agency and not part of the Division of Medicaid or our larger Department of Health and Welfare. Our vision was to capitalize on the new managed care program for dual eligible individuals by altering the contracts Medicaid held with the insurance providers to include the sharing of resource database and some limited caregiver services that would be delivered through the plans. After several conversations, shared goals were identified that created the opportunity for the Idaho Caregiver Alliance to submit a request for funding to Medicaid for a regional 2-year caregiver support pilot program that would be support the sustainability of the Money Follows the Person or Idaho Home Choice programming. And for those of you that aren't aware of the Money Follows Person initiative, it is focused on moving individuals who have been institutionalized back into community-based settings. Leadership within the Division of Medicaid recognized that augmenting support for family caregivers was important to the success of the Idaho Home Choice program. And the Caregiver Navigator project was realized with a 2-year, $600,000 funding award from the Division of Medicaid. I would be remiss not to mention the very talented proposal development team of Marilyn Sword with the Idaho Caregiver Alliance and Tammy Sorrell, formerly with the Idaho Commission on Aging and now with our public health system in Idaho, of making this project happen. So to get into the details, a bit more details of what this project looks like, I'm going to provide just a quick walkthrough of the intervention. So with these resources, the Idaho Caregiver Alliance launched the Family Navigator program. This intervention is telephonic and uses the evidence-based TCare platform for assessment, care plan development, and caregiver follow-up. The platform also includes a resource database populated with a wide range of supports that may be needed by a caregiver. The intervention is powered by self and provider-focused referrals and is available to any family caregiver over the age of 18 in the southwest region of Idaho. You do not have to qualify for Medicare, for Medicaid. It is open to any family caregiver in the southwest region of Idaho. A family caregiver accesses the navigator by completing a brief screening. Once this is completed, the navigator reaches out to the caregiver and invites them to participate in an in-depth assessment that establishes a picture of the caregiver's level of stress, objective burden, and identity discrepancy. This information is provided to the caregiver and the navigator in the form of a dashboard. And this is what is used then as the basis for the development of a person-centered care plan. The navigator guides the caregiver to identify meaningful goals based on the caregiver needs, identify available resources, and help the caregiver make connections through warm handoffs or direct contact with agencies. The navigator also follows up with the referring entity to let them know contact with the caregiver they've referred has been made, in an attempt to close that loop of connection and communication within the community and system. The TCare platform also provides for a weekly automated text check-in message with the caregiver. If elevated levels of stress are noted, the navigator receives a message alerting them for the need to reconnect with the caregiver. In addition, a 3- and 6-month follow-up assessment is conducted with each caregiver. The TCare platform is approved as a CMS 1115 waiver qualified program and is ACL accredited. As we launched this 2-year pilot, we felt it was really important to capitalize on existing evidence-based tools. TCare has a demonstrated record of impact in Washington, and it presented an opportunity to test an Idahoized version of the platform in the Idaho environment. So the Navigator program in Idaho began in June with the hiring of staff. And since June, outreach has been our primary focus. Some of our outreach efforts have included the establishment of a multi-sector advisory committee with a focus on engagement with healthcare providers, healthcare systems, insurance providers and payers, and organizations who come into contact with caregivers across the lifespan. Over 50 presentations to community and professional groups reaching over 300 individuals have been conducted. The audience for these presentations have ranged from the United Way with its extensive network of community connections, to the Idaho Women's Leadership Conference, to the information and assistant staff with the local area agency on aging, to healthcare providers. We have really tried to throw the net wide in terms of building awareness and also establishing our own knowledge of the systems that are available. As Jason mentioned, that importance of understanding what others are doing are key to success of these ventures. Our other primary outreach effort has been the development of a website, caregivernavigator.org, as well as print collateral. And I've provided some examples of our print collateral here, a pamphlet, several postcards, and an RX pad that's specifically designed for a healthcare provider, a social service provider, to hand to a caregiver, encouraging them to reach out to the Caregiver Navigator. A key component of the infrastructure was identification of the entity that could hold the contract with TCare, and our local area agency on aging, thank you Raul Enriquez and team, stepped up to fill this need, and we were ready to roll. The project was launched on September 1st, and the navigators have completed 24 assessments. The aha moments shared by caregivers who have just been remarkable. For example, a caregiver who said, "Oh, now I get it. This is really about me and my health and well-being." Or the caregiver who remarked on the value of understanding the issue of identity discrepancy and letting go of the guilt and frustration she felt about being a caregiver and not a wife. It's been a busy first month, but full of rich learning experiences. And our next steps, we will continue with a robust, rapid PDSA, Plan, Do, Study, Act process evaluation strategy, making changes to outreach, delivery, and follow-up as needed. We're also preparing to launch outcome evaluation efforts with an eye on the needs and interests of multiple stakeholders, honing our efforts on caregivers, what's important to caregivers, to healthcare systems and providers, to insurers and payers. How does this connect to value-based healthcare delivery? What's important to public entities and community-based organizations? And we will continue to conduct our outreach efforts, knowing that individuals, healthcare providers, social service agencies have many demands on their time, and it is incumbent upon us to keep this resource on their radar, particularly when working with a relatively invisible population like family caregivers. At the completion of the 2-year pilot, our goal is to have an evidence-informed list of recommendations to guide future actions in Idaho. And with that, Judy, I'll turn the time over to you. And you are on mute.
Thank you so much, Sarah. Very quickly, some lessons learned around the project. The first is that projects should always and must be built on the foundation of daily work. We were only able to take on this project, which is taking our caregiver program hopefully in a generational leap, because of years of the non-sexy daily work that we've been doing. That includes our positive reputation and partnership with Medicaid, and the other interested parties we needed to bring to the table. That's been cultivated over years of showing up and doing work, of partnering when asked, and also doing caregiver conferences across the state where we've engaged directly with caregivers and had really done that stakeholder analysis of what they needed and what the gaps were. We do very robust annual strategic planning and have a brand new state plan that clearly honed in on caregiver support as one of our highest 3 priorities. We do continual gap analysis of all of our programs, including caregiver. We already knew the questions that we needed to answer for the next steps. We already knew some of the major gaps of our program from having listened to multiple stakeholder groups. The other thing we knew is some of the tools that we lacked. So when an opportunity came, we already had done the foundational work of what do we need this opportunity to do for us to take the next step as supported by our strategic and state plans. The other thing we had done is guarded our resources until the right opportunity came along. For everything you say yes to, there is an opportunity cost. Anything you do excludes many things that then you can't do. So one of the lessons learned is make sure you don't put anything on your plate that is not advancing that strategic vision that you've already hopefully elucidated through your daily work. We will be back for the question and answers. I know we're a little behind time, so I want to stop here. And thank you so much again for this opportunity. And we look forward to answering any questions that you have at the end of the webinar. Bye-bye.
Thank you, Judy and Sarah. That was so great. And yes, just as a friendly reminder, Q&A icon at the bottom, you can ask a question at any point and we will get to some of those at the end of the presentation. So without any further ado, we're going to turn things over to Julie in Iowa. So Julie, the floor is yours.
Okay. Thank you, Courtney, and kudos to our colleagues in Virginia and Idaho for their programs. I'm anxious to go out and check out your websites and continue any conversation via email and Zoom. Again, my name is Julie Bergeson, representing the Iowa Department on Aging, and it's a pleasure to talk with you this morning about our work during this 18-month project, and specifically how we are guiding family caregiver programs through data collection and information exchange. Next slide. Just a little bit about us. The Department on Aging was established under the Older Americans Act as a state unit on aging, and we are a standalone executive branch agency within Iowa state government. The department strives to improve the quality of life and care of older Iowans, individuals with disabilities, and family caregivers through advocacy, planning, policy development, and the administration of services that promote health and safety, and long-term independence. As you can see on the map, Iowa's Aging Network and our 6 local area agencies on aging, how they are divided into service regions. Our goal at the department is to provide resources, tools, and technical support to our aging network to effectively deliver our core services of information and service assistance, nutrition and health promotion programs, and services to promote independence to our consumers and caregivers. Next slide. Our goal throughout the project was to streamline service delivery processes to better support Iowa's family caregivers, identify what they need, and are we or can we provide those wraparound supports that they need, and to collect more consistent data to accurately reflect activities conducted under the National Family Caregiver Support Program. The National Family Caregiver Support Program was established in 2000, authorized again under the Older Americans Act, to assist family and informal caregivers the supports to provide care at home for as long as possible. Like Jason talked about, home and community-based living. How can we support the caregivers, which ultimately support the care recipient, to keep them both at home longer? Next slide. The ultimate outcome for our work was to develop optimal supports for Iowa's caregivers. We knew from existing data large variances across the state, and kept asking why. Are caregivers receiving a similar menu of services across the state? How do they access those services? Those are just some of the questions that we had, and needed a better picture of the needs and existing gaps for Iowa's caregivers. Through this project, we developed a minimum set of standards and data for our network, understanding that there are, within our 6 area agencies on aging, there are differences in needs of their regions, from diverse populations, urban versus rural, socioeconomic factors. So we always want to allow flexibility for those, but we needed to set a standard for all to follow, and then each AAA can go above and beyond if they so choose to better meet the needs in their area. This information and data collected going forward will help both the state and local level in strategic planning. If you've ever done a state plan, area plan, it will help those efforts, future program enhancements, and communicating the needs of Iowa caregivers to stakeholders, other state agencies, and legislative branches as requested. Next slide. So what did we do? We decided to begin this undertaking with a 3-day continuous improvement event held in late April, early May of 2019. In Iowa, we called this LEAN, a LEAN event, and we had 2 outside facilitators join us to help guide the process, to be that outside voice, able to ask difficult questions and push the group forward. The event brought all levels of both Department on Aging staff and AAA staff together. So in the room, we had executive directors to middle management to frontline staff together, so that all voices could be heard, and everyone had ownership in the process and final product. In the event, we really started with clarifying a common definition of a family caregiver. The definition in the Older Americans Act is purposely very broad, leaving a lot of room for interpretation, and we certainly had multiple interpretations. This was really an important discussion and critical kind of first steps in our process. All AAAs brought to the table their high-level steps of how a caregiver obtains services in their region. We then identified similarities and differences and began developing one common process flow through our system. You can see our process map on the slide. You probably can't read it, and that's okay. This is our process flow of how a caregiver enters our system and receives services. And really the important key there is we went from 6 different maps to one standard process flow. The actual event was really just the beginning of our work. Throughout the next few months, smaller work teams got together for various projects, including recommending protocols for services, reviewing many existing forms, and conducting a thorough national scan of assessment tools. This scan included, we looked at medical models, those from the social work field, the evidence-based assessments, assessments developed from other states, really across the board review. We were trying to find real balance in developing a comprehensive and thorough tool, but also one that was not cumbersome for the caregiver. This group landed on a mix of 20 questions to gain a better understanding of the caregiver's current need and situation, and tagged onto that is a 13-question modified caregiver strain index, which is a more recent version of the caregiver strain index initially developed to screen caregivers after hospital discharge of an elderly family member, developed by the Hartford Institute on Geriatric Nursing at New York University. The index targets 4 domains of strain: financial, physical, psychological, and social or personal issues. Together with those tools, an options counselor or AAA staff can they are better able to identify caregiver needs and focus supports on those specific needs. From this work, also standard operating procedures were developed and a statewide training webinar conducted in December of 2019. Throughout this time, we worked with the AAA system administrator to implement the assessment tool into our statewide data system, which is WellSky. All 6 AAAs use the same data system, so we are only pulling it from one source, and it went live in January of 2020. Next slide. We wanted to share some initial findings with you. And first, you will notice in the upper corner Tableau logo. Tableau is the data software visualization tool that we use to aggregate the data from WellSky and put into a more user-friendly, readable format for both the Department on Aging and AAAs across our state. These individualized dashboards allow IDA management, program staff, or AAA staff to really view the data at a level that they prefer. It could be that management wants that high-level overview, but some of us like to get in the weeds, and so we're able to do that by manipulating the dashboard. So happy to report that Iowa's Aging Network served just over 1,000 more caregivers from state fiscal year 19 to state fiscal year 20. 234 caregivers completed the assessment tool in 6 months since implementation. That was January 1st through June 30th of 2020. I didn't dig deep to see how many of those were from March to June, but we have a total of 234. I should note that here that not all caregivers that we come in contact with receive an assessment. We chose to begin with those that receive a more in-depth consult with the AAA for options counseling or caregiver case management. So not those that receive maybe a one-touch service like INA, information and assistance, receive an assessment. Initial findings from the tool show that caregivers taking the survey ranged from age 26 to 98 years old. So We cover the whole range from millennials to boomers to the silent generation, and most are providing daily care for their care recipient. Of those 234 caregivers, 47% are caring with someone for Alzheimer's or related dementia. This information is critical as we look to develop more dementia-specific interventions and identify caregivers and care recipients at high risk for institutional placement or just high care needs. For a majority of caregivers that completed the assessment, at this time, caregiving is not affecting their work. I will note here that our assessment tool is very concise, but can be expanded upon in the future. For example, this question right now, we've simply just asked if caregiving is affecting your work and can provide counseling from there. But in the future, we can add many more questions on how is it affecting your work, and add those things in as landscape shift. We work with more partners. Many of our questions on our assessment can be expanded upon to gather even more information. We kind of started with the basics and got it rolling, and it can be adjusted. And almost half of those caregivers indicate a high level of stress according to the Modified Strain Index. This data is just the beginning. Our next steps include taking a deeper dive into how our network can support high-risk caregivers. By developing the caregiver assessment tool, our AAA field staff, and together with caregivers, can better understand needs and determine the appropriate information, services, and community supports that allow caregivers to remain healthy and remain in their role in caring for their care recipient. I would also like to thank the Center for Healthcare Strategies, our funders, who have been very engaged in this process, my AAA counterparts, and really the other states involved. That was a pleasure to have those conversations and several webinars and phone calls, I know with Idaho, and some email correspondence with Virginia. So that collaboration at the national level was really much appreciated. So thank you. I will turn it back to Courtney.
Thank you, Julie. Appreciate it so very much. And again, huge thanks to all of our speakers. We're going to move to a Q&A now. So again, feel free to touch the icon at the bottom and you can enter a question at any point. So I will get started here. I know we had one right off the bat for Judy and for Sarah. The question is, it was wonderful that you were able to partner with the Money Follows the Person program. How will you expand and sustain the telephonic intervention? And how did you utilize your lifespan respite grant to initiate or advance this work?
Thank you for that question, Jill Kagan. Great to see you in participating. And I do want to extend our appreciation for the resources we have received through the years through the lifespan respite funding. That has been our foundation for the Idaho Caregiver Alliance. And without that alliance, without that established reputation of working across sectors, across populations, we would have had a significant gap in achieving this opportunity. So it has been key to that. The sustainability of this project, we are still visioning this as a public-private partnership. Every time we meet with a healthcare provider, a healthcare system, a payer, we're asking, how does this fit into your world of value-based care? How can support of the caregiver help you achieve your goals? Because together with state, federal funds, and also that private entity, that's what builds a sustainable system here in Idaho. So, Judy, please add to that if you.
No, I agree. Certainly, as I said in my opening remarks, government is a resource of last resort, always. And so we are making sure that we've involved those private partnerships from the start, that our data collection plan is covering the data that they would need to take to decision makers within their organizations. So we certainly have a vision that in 2 years, the value of this program will be self-evident from the data we collect, and we will receive funding ongoing.
Thank you. That was great. This is a question for everyone. How have you measured your return on investment in this space? So what sort of measures have you taken in account in measuring your success? And I know some of these projects are still kind of getting off the ground here, but wondering if any of you have thought about measurements and measuring success. What does success really look like to you all?
Well, this is Sarah from Idaho. I'm happy to kick that off as well. That's really been a primary motive of ours from the beginning, because we know that without data, we will not have the evidence to support that, I believe, essential public-private partnership. So really trying to, through this advisory committee that we've had around this project, really using that to help us inform and guide our evaluation strategies, and data collection are key. At this point, a month in, we're a little too early to begin really seeing this measure of value or impact, but the TCare system as well, it is primed to look specifically at reducing the intent to place in an institutional environment. So that measure, as well as the stress indicators, change over time, those are all part of the TCare assessment that we're hoping we're going to be able to elucidate kind of the impact of having this access to resources and supports will have. But we also recognize we're going to have to gather some additional information as well.
Hey, Courtney, it's Jason. I'll take a add to that. So for Virginia's return on investment for this project, I think the first one is maintaining that momentum of the work group, getting together, continuing to get together, and I think at this point we're really excited by the opportunity to. We now have that lens, maybe a better way to say it, the lens to look through and say, hey, we're talking about something. What does it look like when we look through the lens of better supporting family caregivers? I use the VCU survey as the example. Quite frankly, and I'm almost embarrassed to say it, we probably wouldn't have said, oh, hey, let's add a caregiver supplement to this survey. We just wouldn't have done it, right? And now with, now having this lens of taking our existing work and saying, now let's look through the eyes of a caregiver or how to better support a family caregiver. I think that's going to be real success for us is we make it more part of our, I think Idaho said it, our daily work, right? The non-sexy stuff, right? But you make it part of your daily work, and you really can get a lot done. So I hope that's what we're able to achieve kind of going forward, and certainly we'll consider that as a success. So thank you.
Yeah. And certainly for us, we are still in kind of that infancy stage of things. But hopefully through this project, we have set the stage a little bit better for our aging network to begin those strategic partners, public-private partnerships with different entities and payers. You know, we stuck with kind of what we had authority or some level of control over, and we're now better able to go forward. So we started maybe small, but positioned ourselves better for the future.
There's a question about reaching out to family caregivers in rural areas. And since all three of your states have some of those areas, the question is about, has there been anything in particular you all have done to try to reach family caregivers in rural communities, particularly in light of COVID-19 and people being in their homes more? So any special strategies for outreach there?
Yeah. In Iowa, many of our area agencies on aging have initiated electronic communications with caregivers via a device called a GrandPad that does not require internet access, so connectivity is hopefully not an issue, but caregivers are able to better communicate with their families, with the AAA staff to touch base as needed. They're a very simple device to use and are having great success with that new technology given COVID. And you know, much like Idaho and other states, we are very rural as well. So this is something that COVID kicked into gear, but something that really could continue going forward.
This is Sarah from Idaho. I really appreciate that the connection with law enforcement, and that is a key element of really connecting with those at most distress. And our work that we've been, our efforts here in Idaho have been to include on our advisory group members of our first responders, and thinking particularly about our community health paramedic programs that we have in the state. So bringing them into part of, because they see that on the ground reality within people's homes in rural settings as well as more urban areas. So I think through our CHEMS providers, our community health EMS providers, as well as through our community health workers, working very closely with the CHWs in rural areas to connect. A shout out for rural here in Idaho. We have launched a consumer-directed respite program with the support of the Lifespan Respite Funds and really through the leadership of Idaho, the Commission on Aging. And I think that respite, that consumer-driven respite really enables access to resources and supports in those rural areas. So hats off to Judy and her team in launching and supporting that consumer-directed approach.
So Courtney, as you noted, in Virginia, of course, we do have some rural areas as well, and we actually shifted gears just slightly as it related to addressing the pandemic, and that partnership that I noted earlier with regards to Virginia Navigator and the email campaign actually focused on stress management and in getting out stress management and coping tools and resources via the email blast to our list, and making sure the care coordinators were aware of them in case they noted that when they did their assessments. So, you know, we felt that being able to you know, get that information out and make it as applicable to the situation, you know, as we could was our way of pivoting just a bit and trying our best to kind of accommodate the very rapidly changing world that we're all in at the moment. So that's one tactic we used. Thank you.
Makes sense. Sarah and Judy, this would be for you again. How many care navigators are needed in order to have personalized one-on-one for everybody who maybe wanted one? And how does that kind of vary by the type of family caregiver or the type of care recipient that's being served?
Well, I'm not sure in our presentation we called this out, but we are doing this as a pilot in only one of our area agencies on aging currently. We like to start small, of course, work the kinks out, get our learnings early before we try to replicate and roll across the state. So part of not having to reach all the rural areas so far from your previous question is that this is a single area pilot currently. And then I'll let Sarah talk about the number of FTEs we currently have dedicated.
So the recommendation that we've had from TCARE and we've also, the Center for Healthcare Strategies is also connected with Washington, and so we've been able to counsel and learn from them, is they estimate approximately 1 navigator for 50 caregivers is kind of the load. Currently, what we have funding for is about 1.5 navigator. We are currently working with a private partner to see if we could expand that to another navigator position and connecting with our Masters of Social Work program at the university and having this navigation role serve as a field experience for an MSW student. So we're super excited about kind of integrating this awareness of caregiving, this really important, I think, social work, social service skill of person-centered care into the curriculum. So trying to think of ways that we're going to be able to grow this program, but recognizing kind of that fiscal limitations of how do we expand our capacity. So those are a couple of strategies we're looking at, but currently what we've heard is about 50 caregivers to a navigator.
Great.
But to that comment, this navigation role it's pretty heavy. So building in for the navigator that there's a timeout for them as well, so they can rejuvenate and kind of reestablish their own space and head. So I think that's a really important element here. It's not quite like counting hours on a clock. It goes with you in this work. So I think that's another piece of the protocols that we're developing is how do we ensure that we've got a timeout for rejuvenation.
Thank you, Sarah. Jason, one for you. I appreciated for sure your honesty with talking about your multi-stakeholder task force kind of work group that you all formed, and that wasn't easy all the time, you know, to come together. Once you guys did, it was great, but you know, it's hard to do that work. What do you think brings people back to the table when things can get tough? What advice would you give to another state who wants to give this a go?
Gotcha. Yeah, no, great question. Thank you, Courtney. I always rely on the first form as kind of that common mission. You know what I mean? That if we can, we might have specific agendas or specific, key areas for ourselves and for the programs we oversee. But, when you break that all the way and at the core, what's that core mission? And, it's probably going to be real close, despite, so that kind of starts it for us, or at least in my approach. And then, what we did early on is we didn't have additional funding when it came to, if we do this new thing, there'll be money to pay for it. That wasn't really kind of part of the equation. So we wanted early on to establish the core mission, and then again, find those existing work streams where we could just attach some family caregiving to it. And we worked real hard to do that real early, so it would bring people back to the table. Then, hey, this isn't one more thing Jason's asking me to do, and I'm not going to get any additional resources for it. This was something that I'm already doing, and hey, there's a better way to do it, or we can make this a little bit better by again adding that caregiver, supporting caregiver thing. So I think those were the key two elements that I'd say were really successful in establishing the core mission, and then similarities across groups, and then adding to just kind of enhancing or refining existing work and not just one new thing that's unfunded.
Makes total sense. Yep. And one last question, and Julie, this one's for you, if you don't mind. Same kind of flavor with advice for states going forward. You know, your statewide assessment is really impressive that you all were able to put that together. Any advice for a state who maybe wants to give that a go? You know, what are some of the first steps that you'd recommend?
Sure. I mean, the first step is really know your why. We all don't, caregivers especially, just don't need another assessment. You know, there's a lot out there, but really, what's your goal in implementing a caregiver assessment? And really, our goal was, you know, to identify the caregiver needs and how can we wrap those services around them effectively. That was our goal. The assessment was a tool to help us get there with data as the end result. So really, you know, start with the why. Like I said earlier, time to discuss those definitions. That sounds really elementary of what is a caregiver, but it was critical to have everyone on the same page, and we could still be there maybe talking about it had we not had trained facilitators to help kind of guide us. And really from that event, we also had a really detailed implementation plan with dates and steps to keep that momentum going forward.
Thank you, Julie.
Yeah.
Well, I'm going to move us, Travis, if you will, just to our final wrap-up slides here before we say goodbye to everyone. So before we sign off, just a huge thank you to our speakers, our funders, and all of you today for being here with us. Again, I just wanted to mention, like I did at the beginning of the webinar, that CHCS released this brief on Tuesday. If you haven't seen it yet, there was a link to it in the chat if you'd like to read more about what all 6 of our states accomplished during this project. So that's there. And again, if you're interested in learning more about phase 2, please don't hesitate to contact me or anyone on our team. And we'll be happy to talk through more of that with you and see if this could be a good fit. And then finally, just the last little bit here, when you sign off, there will be an evaluation, and we'd love for you to complete it. Your feedback really helps us shape presentations going forward. So appreciate that. But thanks so much to everyone. Appreciate you being here, and enjoy the rest of your week. Thank you so much.